So what we've been doing for the last year or two with the Academic Health Science Network is coming up, supporting people, particularly around thinking about long-term conditions with technology-enabled care. So that's sort of linking the thinking that's going on with NHS England, and I'm on with one or two other people who are in our group on the steering group for NHS England, as well as the thinking behind the Academic Health Science Network, which is the partnership between NHS, academia and industry. But most of all then, taking it down to the front line. You can only go down to the front line if trusts, CCGs, social care are signed up to getting technology-enabled care out there. So I'm just sort of going to give you a little talk through the kind of things we've been doing over the last year or so, but focused on long-term conditions, which automatically also means lifestyle habits. So, you know, you're only going to get business cases agreed with clinical commissioning groups or with trusts or with local authorities if it makes sense. So it's only going to make sense most automatically is if you focus technology-enabled care on different stages of long-term conditions where you can make a difference. So that would usually be trying to prevent deterioration or trying to spot signs that people are deteriorating so that you can do something so they're not admitted to hospital, don't go to A&E, they're more able to look after themselves, they're less likely to be readmitted, they're more likely to take their medication or agree to carry on with the interventions that people have set up with them. So we have to remember how many people have got long-term conditions in the UK, and particularly to remember that we have an increasing percentage of elderly population who are most frail. But the kind of thing that people don't talk about very much, or they do talk about it and don't do much about it, is the frequency of multimorbidity. And again, that's bringing in the difficulties with technology-enabled care. Because if you have a sort of keen person in cardiology that's dead keen on doing something with telehealth with heart failure, which is what we're doing locally, what about the fact that they're also depressed or got dementia? What about the fact that their carer actually needs to understand as much about the heart failure as the clinician? We have got to think of all the different mix that brings in there. You've also got to think with the multimorbidity how you're going across the settings between acute care, primary care, community care, mental health care, and very much social care. So we've got to realise that if you are, for instance, doing flow telehealth and you're trying to get people to control their blood pressure, that blood pressure control is different if they've got chronic kidney disease or diabetes. You've got to try and strive more. So one thing, you can't just take and blip it against everything to do with hypertension. It's all got to be individualised, either individualised for the setting or the patient, or in some way to then work across the settings. Now the sort of methods that people mostly talk about at the moment for technology-enabled care, and this has come from the NHSE steering group, is Skype. That might be just Skype or encrypted video consultation apps, and they might be the ones from the NHS Health App Store, which should have a CE mark, but that doesn't mean to say that everything about them inside is what a clinician would consider reliable. Telehealth, which might be interactive, or it might just be information. And we also add in here social media, because we do quite a lot in our rollout with the AHSN project that's around closed Facebook groups, or open Facebook, or YouTube. And for instance, there's such a powerful video that we were watching the other day that's come out as one of our sort of projects. And a practice just decided to do it, and the GP who decided to do it is a GP with special interest in TIAs, transient ischemic attack and stroke. And there he is just talking to his patients for about 10 minutes to try and help people modify their lifestyle habits so it's less likely to have a stroke. And it is so powerful, just those sort of things, that I would call that within technology-enabled care. It has not got to be some very expensive equipment with a non-clinical triage centre that would cost an awful lot of money, that when a threshold's reached, somebody responds to it that day. It can be just anything that's very simple and helps with remote delivery as an option. So there are the organisational challenges that I've already talked about. One is, again, about justifying the evidence, the expense of it, who's going to do it, is it some sort of extra, or why on earth isn't it just integrated in the way that we do deliver health and social care? So thinking about it, when one's trying to think about integrated care, we've got to think that the most likely impact you're going to have is when someone sort of owns it. And so probably if I asked all of you, most people will have something on their wrists at the moment which is monitoring their exercise, their heart rate. Wherever I go, people are always showing it off to me. Someone showed me yesterday, it's monitoring how long he slept for last night, how many times he woke up. It's really getting to people, all these wearable technology, and it's obviously being developed a lot. So it might well be that a person has chosen their own, finds something out, like they've got an irregular heart rate, and goes to their their GP. Could be in primary care, but we mustn't just talk about general practice. We're trying to trial telehealth with pharmacies. And again, if we can get that more interaction between general practice and pharmacy, that will strengthen things. If we can get more interaction between people and pharmacists, they'll be less likely to go to A&E, they'll be more likely to trust the pharmacist. So there's bonuses for everyone. Community care and social care, we've got to always remember assistive technology. They're way ahead than the NHS. If you go and find out what that is in your local authority, you'll see there are exit sensors, so you can check if someone's going out their front door, fall sensors in their bed, whatever. And then secondary care. The kind of things that are coming out from secondary care the most seems to be, for us locally anyway, Skype, and that might be for multidisciplinary team meetings, or it might be between clinician and patient, or it might be the closed Facebook group. We're doing that locally at our local hospital at the moment for cardiac rehabilitation, MS, and AF, so that patients can talk to each other and the clinicians can put in their stuff about once a week. So it's a sort of very difficult to have all these fractions in the local health economy. Somehow we have got to work together. Now, one of the advantages that has come out for us locally over long-term conditions is in trying to get heart failure with post-discharge use of flow telehealth. Then you need to make sure that we're all using the same clinical protocol. So there is the consultant cardiologist, who is a very assertive man, who leads Dargoy Sachi at our local hospital trust. And he wants the protocol that the community heart failure nurses think is too brave, so that if someone's putting on a bit of extra fluid which shows their heart failure is going off, he wants to up-titrate the medication. He wants even to help the patient see when they should do it. The community heart failure nurses are a little bit standoff from that, but the GPs are addressing it. So it's enabled us, this technology is driving us to have the same clinical protocol in general practice, which we didn't have before, with what the consultant's doing. So we're finding all sorts of benefits we didn't expect. And if you're going for a busy slide like this, a busy setup across the health economy, then we all need to have the same protocols. So I went with one of our colleagues to the Mental Health Trust last week, and we were talking about our Skype protocols, and we're sharing them. We're sharing our privacy impact assessment standard operating procedure, the ones we've got agreed in our CCG. And then we borrowed somebody's in Nottingham and modified ours. We've compared ours with what the Community Trust is using, and now we're lending it to the Mental Health Trust so that they can do the same. We share our protocols. So all of these ways of making this work is by somehow working more interactive and collegiately. Again, this is just the way that the health service works. all of these little blots on here, mental health, end of life, public health, they all lend themselves to more technology-enabled care, so that there are more links between all these units within our health economy. And this has been my go at trying to say what integrated care might look like. It might be that at the top, I'm suggesting that in real time, clinicians or social workers in completely different settings might share the care for that same person. They might be using something like Flow Telehealth, where they could link up. You might be having Skype at the same stage as telehealth, but they're sharing with the same protocol. Go down a step to the blue one, and that could be where a clinician or social worker passes over. So in the post-discharge of heart failure, you could expect the consultant might monitor them with telehealth for a couple of weeks and then might pass over to the community heart failure nurse or the GP, but you need to be sharing the mode of technology or agreeing a way that you add in your kind. Multidisciplinary protocol could be within the same setting, so it could be in an integrated care team, a social worker and a GP. Shared care by an individual professional with a patient could be a GP and the patient. And the last one at the bottom, well, a patient could initiate this, get their own app, and it all go up through the system. To make it work, then, you're going to have an alignment with the national strategy. And this is a slide which is taken from the Technology-Enabled Care Services Commissioning Resource Toolkit, which NHS England's provided. Again, it's trying to also say that if you're at the top, you're at the risk at the top, which are the patients who are most likely to be in and out of hospital, the most expensive ones, then it's going to be worth you investing in technology that takes more effort. If you're right at the bottom and there's not much risk, someone's got a long-term condition, got hypertension, and you're not going to have to do an awful lot of interventions, but you need them to comply and adhere to a shared management plan, then you're going to do perhaps a mobile app, something cheap. And again, that's getting people thinking about what the investment's worthwhile for the type of patient, the type of long-term condition or multi-morbidity, the benefits that are likely to come out of it, and the effort that's worth putting into it. And again, that's thinking of that risk stratification. So usually people go for the top 5% of the ones who are the most frequent readmissions or the most likely, like end of life, to need an awful lot of input. And then at the bottom, 80% are the ones with the long-term conditions, probably only one, that are most easily controlled. And I'm assuming Theo will put these slides on the internet and then you can look at them at your leisure. This is just the way that they've done it in Nottingham. And this is just showing how in Nottingham they really do think along the whole patient pathway. And this is example of this is with Flow Telehealth, which is the interactive mobile phone testing. And our CCG that I'm the chair of, Stoke-on-Trent, does get royalties from the use of Flow Telehealth. So I'll just press declare that in case it's a conflict of interest. But even the conflict of interest, you need to be thinking, where does the technology come from? Are there particular people benefiting from it when you're thinking what kind you're going to be using locally? But you can see here, and hopefully you can read some of the wording at the bottom, there's huge, wide pathway there. It might be hypertension, there might be lifestyle habits like smoking cessation, it could be about pain, it could be based in care homes, or it could be other settings. In the acute care, they've got it targeted on gestational diabetes, and somebody up at the North East AHSN is doing a randomised controlled trial on gestational diabetes, or hypertension, in pregnancy-induced hypertension. So there's a lot of evidence gathering going on, and there's quite a lot of papers like we've published in the BMJ showing the worth of Flow Telehealth for some clinical conditions that you could generalise to others. And this was another idea we had about a few months ago, which Aoife Donnelly, who's at the back there, has helped with. And we were thinking, how can we get CCGs signed up to the idea of investing in telehealth, technology, whatever. And so we had a go at saying, hey, let's tell a story. And on the left column, we've just picked out there 11 indicators to try and tell a bit of a story. So for asthma, it can be prevalence. How much is the prevalence in your area? How many patients are well controlled? Maybe that's come out of what we call the QOF data for practices. How many patients with asthma were admitted last year? How much did that cost? So you try and tell the story of that pathway. And then on the right-hand column, we've put ideas of different technology, the projects that we've been offering, Skype, Flow telehealth apps, what we could offer them to be trying to address those gaps. And the gaps in green, blue and yellow are showing each CCG. We've done one for every 22 CCGs in this region, how they compare with the 10 CCGs most like them, according to Public Health England, that's the middle column, and how they compare to the NHS England average. So showing this to the AHSN board, they very much liked it, and we've now linked up with Public Health England and Strategic Clinical Network, Health Education West Midland, on how we can really make these regional intelligence packs even more useful for all sorts of long-term conditions, not necessarily with the focus on technology, which is what I'm showing you today, but to try and get clinicians, managers, trust leads, or the public and patients themselves much more aware of how good or bad the delivery of care is in their area. So anybody who's wanting to get technology going on a wide scale needs to understand about the commissioning cycle, needs to understand how you fix it on priorities, and then need to go through the procurement process if that's how it's set up in a CCG or in the local health economy. So for instance, in Staffordshire now, we've got CCGs, trusts, local authorities working together as a Staffordshire Commissioning Congress, and we'll be able to get a lot more of this kind of thing going at scale so that everyone works together, including the Mental Health Trust. Sorry, Lisa. I think I'll just miss that one for the moment. So how do we show impact? Well, it's going to need to be enhanced clinical outcomes to bring the clinicians on board, i.e. people's blood pressure is more likely to be better controlled. Patients need to like it to be able to cooperate with it, to be able to sign up and keep using it in a sustained way, or to stop using it if they've learnt enough that they're now okay without the technology, so they'll comply with their medication or whatever else. So we need to be able to, for instance, with COPD, minimise and prevent deterioration. With the Flow telehealth, if the colour of the phlegm or breathlessness or their oxygen saturation comes to a certain point, the patient will be directed by telehealth to start their rescue medication of antibiotics and steroids. And the sort of fairly small scale evidence we've got shows that they do that, they feel confident, and they're less likely to be admitted. Improving the lifestyle habits. I know there's a randomised control trial going on in Birmingham with Public Health for weight management, for instance. Then you're never going to get the commissioners and trusts to carry on with it unless you can show that you've managed to avoid healthcare use, whether that's A&E or whether that's GP visits, home visits, or whether it is for community nursing teams that they now only need to visit 1 in 3 times and the rest can be remote. And that's a fairly common sort of story. Very much people need to be empowered, so they need to understand more about their long-term conditions, and that's what the evidence shows, is that once they start realising what the biometric measures mean when they're texting them in or getting answers back, then they start realising that they can be sort of on a par with their clinicians and take control. So I'm going to list that one with the, let me just... So I think that's just again saying more of what I was saying, which about is preventing ill health, but also prolonging life and quality of care. And there'll be certain long-term conditions which are down the bottom, which are the most obvious that fit into those sections. But we should still be doing an awful lot on the left-hand side with social care, so that people are less likely to have health problems. We've got to work a lot more closely together. Sorry, I've got too many slides here. Social media is not being used nearly as much as it could be. We are finding so much interest in these Facebook groups that I've mentioned, or like the YouTubes. And when we've held our workshops over the last 6 months or so across the region, it's been social media and Facebook that's really had the most interest. And one of the things that people have got particularly interested in is using it for patient participation groups in practices. And whereas before they've had patient participation groups that have been aged 70 and upwards who've got the time to go, some places now have got patient participation groups in parallel that are at Facebook online that are aged about 20 to 40. So that's been great for getting a lot more patient perspectives in for sort of design of the service. So the discussion points would really be in your minds to take away. Why do at the moment practitioners blank the opportunities to adopt technology-enabled care? So, what can we all be doing proactively to help people realise that they can now get more assertive and start using technology? Why do commissioners and providers ignore digital healthcare? It's difficult because if you do the kind of research that takes several years, by the time you've got the results, that technology's gone out of date. So there's got to be this feeling that you can take service redesign, evaluation, and just actually be doing some of it on trust. There's an awful lot of wariness of the commercial market of technology. You read in books, Health Service Journal, the stands here today, all the things that people can offer. And it's very common for NHS and local authorities to be a bit wary. Is there enough evidence to invest, save? I think it's starting to be now that we're at the tipping point, and that most people would start to realise, well, there is. So person-centred care is the theme of our West Midlands Academic Health Science Network that are examples that I've been sort of going through today, technology-enabled care, so it is aligned to. So it's all around being the right care for the right person at the right time, which then brings in the long-term condition, multi-morbidity, lifestyle habits and their well-being at home. And that what we should do is not stereotype. So even people as they get older who appear to have a lot of frailty and maybe problems at the start of dementia, they can still be shown how to use technology in a successful way. And Lisa and Sue, who are here nodding, have just got evidence, and they had a poster up earlier for how the autographer camera can be put alongside Flow Telehealth so that people can be having pictures during the day to remind them what's happened at the same time as the Flow Telehealth messaging. So we just need to be thinking a little bit more laterally and creatively and finding the right solution for the right person. Always remembering Malcolm Fisk's work with the making sure that we get the standards right for telehealth and telecare, and the book that comes out, which is called the telehealth quality, that the International Code of Practice for Telehealth Services 2016 is something that I've been looking at for about the last 4 years, and it's the kind of thing that I look up on a Sunday or something and read to make sure that I'm doing the right thing. So all I'm really saying at the end there is make sure you're doing the right thing for the person, the frontline services, and as you've also got all the standards and criteria in the background, make sure you do the right thing with that as well. Thank you.